Okay, so within this case study, a female patient, age 37, started to experience adult onset psychosis that developed over a period of several months, and her clinical diagnosis was delusional disorder. Ah? What did I do?
Okay.
Oh. Oh. Ah, you want to do it for me?
Yeah, sure.
Prior to the symptoms of psychosis, she was completely healthy, studying for a doctoral degree, and there were no previous history of mental illness nor neurodegenerative symptoms. Her first symptoms were that she started to believe that people were talking about her, and this occurrence was due to a larger conspiracy involving friends, family, and random people. She believed that they were a part of a larger game and that they were acting out scenes just for her. As her psychosis symptoms worsened, she was admitted into an inpatient state psychiatric facility for about a month, and they diagnosed her with a psychotic disorder and possible paranoid schizophrenia. While she was at the psychiatric facility, the doctors evaluated what could have caused her disorder. During her evaluation, her blood work showed evidences of iron deficiency anemia. Her iron level was well below the reference range. The patient had an iron level of 18 micrograms per deciliter. The reference range for a healthy person is about 45 to 182. The patient also exhibited a ferritin level of 6 nanograms per milliliter, which is lower than the reference range. Ferritin is a blood protein that produces iron and that contains iron, and these levels can indicate how much iron is stored within the body. And ferritin is a biomarker to detect anemia. Lower levels can indicate if a patient may be anemic. Transferrin saturation was also low. Her blood work revealed that her saturation level was 3.5%. Transferrin saturation indicates the total iron binding capacity in the body. The iron binds to transferrin in the blood and helps red blood cells in carrying oxygen to other cells within the body. The patient also exhibited other deficiencies like a vitamin B12 and vitamin D2 deficiency. Before her admission to the psychiatric facility, the patient had no previous history of a psychiatric illness. She had a right oophorectomy at the age of 17 for a torsion of the ovary and took no medications. Her mother described the patient as a perfectionist, and the patient did experience an unspecified period of unintentional weight loss. The patient lost about 9 kilograms. However, the patient did self-describe polyphagia, which means that she eats excessive amounts of food. As for the patient's family medical history, her mom had systemic lupus, her sister had hypothyroidism and hyperparathyroidism, her maternal grandfather had diabetes, and her aunt had breast cancer. However, no one within the family had a history of a psychiatric disease. After the patient's 1-month stay at the psychiatric facility, she was discharged and given medications to help with her psychiatric symptoms. She was given risperidone, straterolene, ferrous sulfate, calcium, vitamin D, vitamin C, and a multivitamin. The patient had a follow-up 6 weeks post-discharge and was evaluated by an internist at her primary care physician's office. The internist found her excessively thin, and so they called for an examination of the thyroid. Upon examination, the patient had a thyroid nodule, and she was referred to an endocrinologist. The thyroid nodule was biopsied, and the biopsy specimen indicated Hashimoto thyroiditis and papillary thyroid carcinoma. A radioactive iodine treatment was suggested for the papillary thyroid carcinoma to remove the thyroid tissue. However, the patient opted for a total thyroidectomy, which is the surgical removal of the entire thyroid. After the thyroid removal, the patient was administered escalating doses of levothyroxine, a medication that treats underactive production of thyroid hormone. However, the patient's thyrotropin levels remained high even after the escalating medication dosage. Thyrotropin is a hormone secreted from the pituitary gland, which instigates the thyroid to produce thyroid hormone. The patient's free thyroxine levels tended to be lower than the reference range, which can indicate that lower thyroid hormone availability was within the body and indicates hypothyroidism. The patient had another 6-month follow-up after her thyroidectomy. Psychiatric symptoms continued despite her prescribed medications, and it was unclear whether her psychiatric conditions were related to these thyroid conditions. Thus, she needed further evaluation. The differential diagnosis evaluated the potential of iron and vitamin deficiencies to induce her psychosis. Iron deficiency may have exacerbated symptoms, but the deficiency alone could not have caused the psychosis. Vitamin B12 deficiency can cause some neurological dysfunctions, but it generally doesn't cause psychosis. Vitamin D2 deficiency is associated with psychosis. However, it's also associated with a bunch of other conditions. So it's unclear whether that deficiency alone is the sole cause of the psychosis. The presence of all 3 micronutrient deficiencies within the patient, however, or even with multivitamin intake, may be indicative of an impaired absorption. The patient also exhibited unintentional weight loss, which warrants further investigation. The patient's mother described herself as as a perfectionist. However, the patient had self-described polyphagia, which makes anorexia unlikely, but bulimia nervosa possible. The patient had a thyroid nodule biopsy which revealed the evidence of a Hashimoto thyroiditis and papillary thyroid carcinoma. Papillary thyroid cancer could not explain the psychosis nor the weight loss, and however, there's evidence of an autoimmune condition that may play a role in finding the root cause for the patient's psychiatric symptoms. After the thyroidectomy, the thyroid tropin levels did not normalize, even with escalating amounts of levothyroxine. Thus, it may further indicate that there's a case of malabsorption.
Impaired absorption of macronutrients and medications may be present in the patient despite the absence of gastrointestinal symptoms. Hashimoto's thyroiditis and the inability to absorb levothyroxine, which is used to treat an underactive thyroid gland, suggest possible causes of her psychosis, in combination with her family history of autoimmune disorders. Celiac disease is a possible diagnosis that could explain all the key features of the case, including weight loss, vitamin deficiencies, poor response to anti-psych meds, and autoimmune thyroiditis. Neurologic and psychiatric symptoms of celiac disease have been reported and could account for this patient's psychosis. Delusional disorder is a mental illness characterized by the presence of fixed, false beliefs that persist despite evidence to the contrary. These beliefs can be non-bizarre, meaning that they may actually be true but are not, or they can be bizarre and completely implausible. Individuals with delusional disorder may experience delusions of persecution, grandeur, and jealousy, among others. These delusions can cause significant distress and impairment in social, occupational, or other areas of functioning. Unlike other psychiatric disorders, such as schizophrenia, individuals with delusional disorder typically do not experience other symptoms, such as hallucinations or disorganized speech and behavior. Delusional disorder is a rare condition, and treatment often involves antipsychotic medication and psychotherapy. Affective disorder, major depression, and bipolar disorder with psychosis were initially considered but ruled out due to the lack of patients' mood symptoms. Schizophrenia was also considered, but onset is typically in younger patients, and the patient was not yet menopausal at 37. The diagnosis of delusional disorder, characterized by the isolated false fixed beliefs, fits well with the patient's presentation. However, a delusional disorder is a diagnosis of exclusion, and underlying medical conditions that could cause her psychosis should be ruled out. So this patient had gastrointestinal involvement that was manifested by weight loss, like we said earlier, and had evidence of malabsorption, which were the deficiencies in vitamins and B12. She also had iron deficiency anemia that was unresponsive to therapy, one of the most common extraintestinal manifestations seen in adults presenting with celiac disease. Furthermore, her recent diagnosis of Hashimoto's thyroiditis placed her in a high-risk group for celiac disease, thus indicating screening should be considered. 3 tests were performed. and IgA tissue transglutamase antibodies, endomysil antibodies, and demediated gliadin peptide antibodies. All three tests are typically used together as part of a comprehensive celiac panel to help improve the accuracy of the diagnosis. The test results are positive, leading to a gastroenterologist to perform an esophagogastroduodenoscopy with a small bowel biopsy. Examination of this biopsy specimen confirmed the diagnosis of celiacs. Celiac disease is an autoimmune disorder that affects the small intestine. When a patient eats food containing gluten, their small intestine becomes inflamed, leading to numerous different symptoms. Over time, continuously being exposed to this protein causes damage to the mucosa and impairs the intestine's ability to absorb nutrients or medications. The gastroenterologist obtained a sample from the tissue from the patient's small intestine called a duodenal biopsy specimen and examined it under a microscope. You can see figure 1 right there. The examination showed significant changes in the structure and cells of the intestinal lining. The villi, which are the tiny little finger-like projections that absorb nutrients from food, were found to be shorter and less numerous than normal. The cells that line the intestinal wall, called enterocytes, were abnormal in shape and orientation. Additionally, there was more immune cells called lymphocytes present on the surface of the intestinal lining. So in figure 1b on the right there, you'll see the increased number of intraepithelial and lemia propria lymphocytes. And we can also see a decreased number of goblet cells and expanded proliferative zone in the crypts in figure 1d. Figure 1e is also the hyperplastic crypts. So in general, normal levels for intraepithelial lymphocytes in the duodenal mucosa should be less than 25 per 100 enterocytes. In this case, there are more than 40 lymphocytes per 100 surface enterocytes, which is far above the normal range and could indicate an abnormal immune response in the small intestine. In a follow-up appointment, an examination of the second duodenal biopsy specimen revealed that the duodenal mucosa had a normal villus architecture. The tissue sample had a normal structure with no signs of damage or abnormalities such as flattened or blunted villi, excess cell growth in the crypts, or increased numbers of lymphocytes in the tissues. This indicates that previous abnormalities observed during the initial examination have been resolved and the tissue has returned to a healthy state. This improvement is referred to as a histologic remission, meaning that the tissue has returned to its normal state as classified by the Marsh system at Marsh level 0. The Marsh system, which categorized the level of damage to the small intestine lining caused by celiac disease. So the themes of this case led us to look at more recent research on the gut-brain axis, the complex relationship between the gut and brain. This axis involves a bidirectional communication system between the gut and the brain, mediated by the enteric nervous system, the immune system, and various hormones and neurotransmitters. In the case of celiac disease, the autoimmune attack of the intestinal lining leads to inflammation, which can disrupt the normal functioning of the gut-brain axis. This disruption may contribute to the development of extraintestinal symptoms, such as chronic headaches, memory loss, seizures, ADD, and psychosis. While the exact mechanism by which inflammation in the intestine affects the brain is not fully understood, research suggests that gut microbiota, the collection of microorganisms that inhabit the gut, may play a key role. Studies have shown that alterations in the gut microbiota can lead to changes in the level of neurotransmitters and hormones that affect mood and behavior. Other studies have found that the gut-brain axis is also involved in the regulation of the immune system. The immune cells in the gut can communicate with the immune cells in the brain, leading to changes in immune functions that can affect brain health. Overall, the growing body of research on the gut-brain axis highlights the complex interplay between the gut and brain and suggests that disruptions in this axis may contribute to a range of health problems, including extraintestinal symptoms and celiac disease. Thanks for listening.